Hello, everyone. Good morning, good afternoon, good evening, wherever you may be. My name is Sarah Jane Demi, and I am the CEO and founder of Demy-Colton. And it is my pleasure to welcome you to the 14th installment of the Demy-Colton Virtual Salon Series, How U.S. Policy and Trends Will Shape Healthcare in 2021, which is sponsored by Bloomberg Intelligence. As some of you may know, Demy-Colton's mission is all about convening biopharma and digital medicine industry leaders to catalyze change. We know we can help drive innovation when we bring individuals together who are dedicated and united by a common cause and shared passion. And in our industry, that cause and passion is bringing therapeutics and cures to people in need. As those of you who have attended our past salons know, Demy-Colton was in the process of launching our new International Business Development and Investor Conference right here in New York City when COVID-19 hit and changed everything about our world and about yours as well. So in lieu of doing an in-person meeting, we launched the Demy-Colton Virtual Salon Series to continue our mission of bringing people together, united with great content. In the spirit of convening people, I would like to mention that we will also be holding our 13th annual Biotech Showcase digitally this year. Over the years, Biotech Showcase has become a premier investor and partnering conference for private, small and mid-cap biotech companies, digital medicine companies, medtech companies, and seed companies, which is held right alongside the JP Morgan Healthcare Conference. We're closing in on over 350 presenting companies this year digitally. So I encourage you to join us, participate, register, present. Before we get underway, I would like to acknowledge and thank our diamond sponsor, Bloomberg, as I mentioned earlier, as well as our founding BioFuture sponsors for their ongoing support of this effort. At Demy-Colton, we believe the Virtual Salon Series will be here to stay even after we get back to our new normal, whatever that new normal may be. So please check our website for the schedule of salons, fireside chats, topics, and participants. It is evolving constantly. And of course, I encourage you to join us at future events. A note about the structure of today's program. The formal portion of the discussion will last approximately 50 minutes, 55 minutes, and it will be followed by a 15-minute Q&A period. You can submit questions in the Ask a Question pane below the screen, and we will address as many as possible. And a note, it's much easier for us to address questions if they are as concise as possible. Please note that this salon will be recorded and it will be made available for on-demand viewing a few hours after we conclude the salon today. Additional materials can also be viewed in the Event Resources tab. As I mentioned earlier, today's virtual salon is titled, How U.S. Policy and Trends Will Shape Healthcare in 2020. Our moderator today is Beth Halpern, a partner at Hogan Lovells. And she is joined by our panelists from Bloomberg Intelligence, Mark Engels-Jarrett, Senior Equity Analyst in Biotechnology, Sam Fazeli, Director of EMEA Research and Senior Pharmaceutical Analyst, Brian Rice, Senior Analyst, Healthcare Policy, all of Bloomberg Intelligence. Welcome you. We are pleased that all of you can join us here today. Please note full bios for everybody are available on our website. Without further ado, I'd like to turn the discussion over to Beth. Beth, the show is yours.
Thank you, and thank you for having us all here in our virtual locations today. There's so much going on in healthcare. We have a lot to talk about in 50 minutes, so we'll try to cover a lot of territory. I want to start with Brian, who can talk about what he sees happening in the policy space. Brian, what are you watching these days?
Thank you, Beth, and hi, everybody. It's a pleasure to be here joining you all today. As we try and set the stage here in Washington, D.C., first of all, looking back to the recent election, I would characterize it as an almost surgical strike that voters executed on Washington, D.C. Certainly, Democrats were pleased to win the presidency. Joe Biden will take over, having defeated Donald Trump. But as you look down ballot, the results were somewhat different when you look at the races for Congress. In particular, looking at the House of Representatives, Democrats are going to maintain a majority, but the size of that majority is going to shrink considerably. And that is not at all what was expected heading into Election Day. Most polls were suggesting that Democrats would actually add somewhere between 5 and 15 seats to their majority. In fact, the very opposite is happening, and Republicans have eaten into that significantly. It's going to be one of the smallest majorities that a Democrat-led House has had in over 100 years. And to add insult to injury, it looks like President-elect Biden may select 1 or 2 members of the House to add to his administration. So depending on how long it takes to get to special elections, that majority will shrink even more. The story is still being told in the Senate, where we're waiting on 2 special runoff elections in Georgia. The potential outcomes range from a 52 to 48 majority for Republicans to a 50-50 split, a so-called 50+1 majority for Democrats, given that Vice President-elect Harris would be the tie-breaking vote. So we don't yet know who's going to control, who's going to be Senate Majority Leader, which party is going to be in control of the committees and dictating which bills get a vote on the floor. If Republicans are able to win one or both of those races in Georgia, we think that will effectively kill, or at least shelve for a couple of years, the ability for progressive Democrats to pass their most desired legislation on the drug pricing and other healthcare areas. So that being said, that puts even more attention on what the Biden administration may want to do unilaterally on the regulatory front. Having earlier this week announced his intent to nominate California Attorney General Javier Becerra to lead HHS, I think that signals a willingness or desire to focus on protecting and expanding the ACA. There have been a number of things that the Trump administration has done in the past 3 or 4 years to sort of weaken the ACA around the edges, the so-called death by 1,000 cuts, after Republicans tried and failed to repeal and replace the ACA in 2017. I would expect HHS to look at things like the association health plans, other things where states have been given greater leeway to try and work around some of the ACA mandates. But I also expect the administration to look at ways to expand coverage, greater levels of subsidies, and then looking at I believe there are still 14 states that have not expanded Medicaid, a combination of carrots and sticks to try and get those states to expand Medicaid as well. And they may be more receptive now, given the sort of double whammy that they're facing in all these states, with lower tax revenues coming in because of the lockdowns and the unemployment driving greater numbers of people onto their Medicaid rolls. So the budget crunchers there might be open to a new 3-year period with a 100% match in Medicaid or other things that the administration may consider. But before they get to their own agenda, there are a couple of parting drug pricing presents that the Trump administration has left for Biden to deal with. And the 2 rules we're going to be talking about in more detail today, the so-called most favored nations model for medicines covered under the Medicare Part B program, as well as the so-called rebate rule that would essentially eliminate the safe harbor protection that drug makers or the rebates paid on the back end from pharma to PBMs and others. Those are controversial in different ways to different groups of people, and we'll go into more detail about that. But I'll conclude my opening remarks there and hand it back to you.
Thanks. There is a lot going on, as you said, and a lot of uncertainty left still, depending on what happens with that Senate race or 2 Senate races in early January. Sam, can I turn to you to hear what you're watching for in the industry perspective?
Thank you, Beth. And just to add my welcome to everybody who joined us today. I appreciate you taking the time, given how many Zoom and webinar and WebExes we have to deal with. My name is Sam Fazeli, as you know from the invite. I'm the senior large pharma analyst at Bloomberg Intelligence, and I also wear another hat, which is to run the research department in the EMEA region, so Europe, Middle East, and Africa, from London. I am currently in France, but normally, in a normal world, I will be working from London, the beautiful Bloomberg London office. So my background is that I am a pharmacologist scientist by training, right up to PhD postdoc and the equivalent of an assistant professorship, but then saw the light and decided to go into finance. And I did sell-side research for about 13 years at various banks, and then I joined Bloomberg. I am very close to my 10-year anniversary within a day or two at Bloomberg, and I came specifically to do Bloomberg Intelligence. So with my other hat on again, back with regards to pharmaceuticals, there are a few things that I am going to talk about globally about pharmaceuticals. I cover the US and European large pharma, so not many companies. And we have wonderful colleagues based in Hong Kong and Japan who cover the large pharma, so to speak, in those territories. So if we do have coverage of that area as well. Specifically focusing on, excuse me, on the European and US pharma companies, the key things, the very, very broad brush things that I'm looking at for next year are obviously the pandemic still and how that pans out. I think several companies were a little too bullish going into second quarter, and they learned their lesson very quickly, and then and they paid the price for that to a degree in terms of guidance. But some were too bearish. If you think about Johnson & Johnson, if you think about Merck, they both came out a lot better out of it than initially expected. And of course, now everybody's still worrying a little bit about how these various outcomes that are going on, the way that the infection is spreading in the US and obviously in Europe, lockdowns, etc. But from a healthcare perspective, the impact of what we saw in second quarter is unlikely to be repeating in the, well, third quarter we've had already, but fourth quarter. So the key is, of course, what happens next year, and we think that that we're going, and we think that we're going to get a specific. I think we're coming out of. Sorry, I got a message. I just distracted me. We've got a year of, I would say, transition as we try and learn how to manage and slowly retreat from the COVID-19 pandemic issues. And also, of course, there's the upside of seeing how many of the companies can actually manage to keep their positive benefit that they saw from the way they changed their business in terms of getting their margins benefit. So much less need to travel, complete a shift to a lot of serious shift to health, digital health. So delivering the sales reps essentially the message via digital systems. So I think a lot of companies have learned to do that, and they're going to continue to benefit from that. Although some say that they're going to go and move back to face-to-face events. Then we have always clearly got the macroeconomic picture, which we'll come back to later. We've got Europe in an enormous depth of debt, basically, which is they have to deal with the money they've been spending to try and keep their economies afloat. The last time this happened in the 08, 09, 10 period, about a year or two after, we saw some severe pressure on drug prices in Europe, which of course has carried on. I suspect we're going to start seeing that again from next year. And that is an easy target everywhere, and especially in Europe. In the US, that element comes through from what Brian just spoke about, which is the Medicaid aspect. So I'm looking to see which of our companies are mostly impacted by the shift in payer mix in the US business. And of course, China, we have the continued expansion of the VBP, which is volume-based pricing, which has been putting some pressure on growth rates in China. So basically, from a pricing perspective, pharma companies are coming under pressure from all directions. And then the other thing that I think we have to think about is M&A. Of course, we look at companies' abilities to do M&A through their balance sheets. There's a couple of companies who have a problem doing that. That would be GlaxoSmithKline and AstraZeneca in terms of the heaviness of their balance sheets. But aside from that, we think that most pharma companies are going to be able to do the sorts of bolt-on M&A that they've been talking about. The problem is the valuations in biotech. which of course they all talk about and have a nag, for want of a better phrase, during their quarterly calls when they're called on talking about capital allocation. But then you still get deals, which we saw, things like the Pfizer deal, things like the Bristol Myers managed to do a deal, Myocardia, and even Merck, who's the most vocal about valuations, went and bought itself a company for just over $2 billion in the private space. And we saw the data for that at ASH. So I think I'm going to leave it there and pass the baton back to you again.
Thank you, Sam. Now we'll turn to Mark. Mark, what are you watching in the biotech industry space?
Sure. Thanks, Beth. And I'll add my welcome to everyone with us today. As Sarah said, I'm Mark Inglesjerd. I'm the senior biotech analyst at Bloomberg Intelligence. I guess my background is in some ways similar to Sam's, although I have a medical degree, not a PhD, but I'm finding a non-traditional way to leverage that. Have not been at Bloomberg Intelligence quite as long as Sam, but so I look after mostly U.S. biotech companies, certainly the commercial stage companies, but also some smaller developmental stage companies. And as Sam alluded to, some of my colleagues also look after European and Asian biotech companies. I guess I'll make a few general comments about things that I'm reflecting on here as the new year is upon us. You know, I think in terms of the biotech sector in general, I think had a fairly good 2020, at least so far. And if you look at that through the lens of share price performance, which, is clearly only one metric, and depending on what index you look at, but, the biotech industry certainly outperformed the broader market, which in and of itself had a good year, by 10 to 20 percentage points, depending on which index you compare to which. And again, for the commercial stage companies, I'll be the first to admit, sort of weathered the COVID pandemic, at least to date, better than I was expecting them to back, let's say, in March. And I say that because, most of these companies deal with biologics, large molecules that have to be injected or infused. And there was really, I think, some questions early on about how they were going to be able to maintain momentum behind those products in the face of the disruptions. And yes, there were exceptions here and there, but in general, they came through that, I think, remarkably well. There were certainly some delays to clinical trial initiations or clinical trial progress. I think those are starting, to resolve as well. So, looking ahead to 2021, Sam talked about some maybe of the evolving macroeconomic headwinds that may not come to the fore.
Okay. I'm off screen. You can just bring it back into it.
Okay. Oh, geez.
But we're expecting, the biotech sector to continue to perform well next year. Again, for the commercial stage companies, there are expectations, again, with certain exceptions, for double-digit top-line revenue growth. As Sam alluded to, there may be some margin, compression as spending kind of normalizes, but that we'll have to continue to monitor that. I think another area that is always on the minds of the biotech industry and its followers is the regulatory climate. And I think, again, focusing specifically on FDA, I think it's safe to say it's been a fairly permissive regulatory environment for the biotech and the pharma sector. Some might actually argue maybe too permissive, and we don't need to get into some of the recent controversies around some of the COVID-19 therapeutics, for example. And, we have the continuing saga, I think would be the appropriate word, of Biogen's attempt to resurrect aducanumab for Alzheimer's disease. We'll see how that ultimately plays out. But, obviously with the transition to the Biden presidency, we'll be having a new head of FDA. And I think that's sort of a wild card and a potential for the regulatory climate to maybe shift a little bit. The other specific item there that a lot of biotech observers have been doing some hand-wringing over is specifically with respect to cell and gene therapy and whether FDA specifically is kind of raising the bar with respect to its requirements for manufacturing and assay requirements. I think that's probably somewhat of an unfair characterization. It's a relatively new area for society, and that includes regulators. I think it's clear that we need some better communication, I think, between companies and regulators. I don't know if it's necessarily the case that FDA, though, is raising the bar, but that's obviously another area we'll continue to pay attention to. And then just to quickly wrap up, because Sam already mentioned M&A, from the biotech perspective, although there are some large players who can be acquisitive, it's also a matter of which companies will be acquired. I think, again, we were surprised, pleasantly so, that M&A activity maintained throughout 2020 in terms of scale and scope, and we would expect that to continue. There is this headwind of valuation that Sam alluded to, and I guess I'll also mention, one of our Bloomberg Intelligence litigation analyst colleagues, Jennifer Rhee, has done some interesting work looking at the potential for Biden appointees to the Federal Trade Commission and some DOJ positions, maybe to have a more progressive view when it comes to antitrust considerations as it relates to larger deals. We'll have to see if that comes to pass and if that has sort of any implications for biopharma deal making. Before I turn it back to you, I'll mention that we've sort of wrapped a lot of this up in greater detail, including some views on Europe and China in a holistic Biotech 2021 outlook report that we recently published. And those of you tuned in can access that. I believe there's a Bloomberg tab at the top of your screen. So please feel free to avail yourself of that resource. Beth, I'll hand it back to you.
Thank you. And thanks to all of you for that great overview of the many, many things on the table right now and on the horizon that we're looking at. I'll give you a little bit of background on me and my practice. As Sarah said, I'm a partner at Hogan Lovells. I'm in our health practice, and my work focuses on coverage and reimbursement for new technologies. And what that's meant over the last 10, 11 months or so has been a mix of COVID-related questions, questions about coverage and reimbursement for COVID, therapeutics, vaccines, diagnostics, especially with the changes in the law, and the Centers for Medicare and Medicaid Services implementing those changes in law and policy, as well as a lot of questions that deal with access to care, some of the issues Mark raised, with how patients were supposed to go about getting care, especially earlier this spring and summer when they were being told, don't go to healthcare providers. So a lot of work looking at and trying to help advocate for changes in policy to allow more use of services in alternative settings of care, evaluating some of Medicare's changes about allowing hospitals to treat homes as part of a hospital, greater use of digital health and technologies to allow supervision and care to be provided in other settings. So this past year for me has been kind of an interesting mix of responding to the global pandemic and trying to help patients who fortunately had not been directly affected, didn't need a COVID therapy themselves, but who still need their cancer treatments and other therapies. How would we help those patients and those providers serve the patients and continue to deliver care? And with that, I want to turn back to Brian, because there's a lot of policy issues we're still facing in the pandemic. It is obviously the number one health issue in the US, and President-elect Biden has made it clearly one of his top priorities. His first personnel announcements were for his COVID task force, and he's repeatedly said that getting the economy back on track and almost every other policy has a connection to COVID. So Brian, what are you seeing as some of the where we're going to go? What are the political status? You touched on some of this earlier, but there are a lot of things left to do with the vaccines that we're hoping will be available in the US imminently, continuing to deliver therapeutics to patients, changing the way continuing to change the way we go about our daily lives. What do you see happening?
So thanks again, Beth, and great questions. I think a couple of things I would focus on in trying to frame that. First of all, as you mentioned, we're at the end of the year, which typically for Congress is a very busy time, doubly so now. And so I get often asked, are they going to pass another relief bill? There are two different bills that they're looking to pass, and they're probably going to roll them up into one. First is, a phase 4, 5, 6, whatever phase you want to call it, relief package for COVID. But then also there is the overhang of trying to pass a full year for fiscal 21 appropriations package as well. And my expectation is that there will be some sort of bill passed, with the base package, either a multi-month continuing resolution or hopefully a full year, omnibus bill. Added to that, I suspect will be some sort of a relief for COVID, whether it's the $900 billion or so that the bipartisan group, and now we have Secretary Mnuchin reinserting himself in with a similar offer as well. I'm not sure if everything in that is going to be included in the final package, but I do suspect you'll see something there. And I think Biden has communicated to Democratic leaders that he would like this phase of it sort of off the plate when he takes office in early January. So would expect there to be something, again, PPE, some unemployment benefits, what have you. On the COVID transition itself, some of the faces are going to stay the same. Some are going to change. Fauci will continue to be, omnipresent on our TV screens. The messaging will have a different tone, but the underlying goals are somewhat the same from what you've seen from the Trump administration in recent months. They're going to try in the first 100 days of the Biden administration. The goal is to deliver 100 million doses of a vaccine. I think you'll see them be much more aggressive in trying to push, some of the NPIs, wearing the mask, and those type of activities around. But the nuts and bolts are probably going to be the same. As Mark mentioned, we are awaiting the, appointees or nominations, new heads at CMS and the FDA, and that is likely to dictate, some of the initial policy steps or some of their key things that they want to see. Also there is going to be a new head at the CDC as well. Dr. Walensky has been nominated there. That's an area that I think when this is all said and done, there's going to be an even greater focus on looking back at, from a public health perspective, what can the system do better than what they've done here. And I guess the last thing, as CMS and HHS hopefully start to return to normal and look at how to react to what's gone on the past year or so, is a lot of things have been done in the last 12 months that were done on an emergency basis. So during the existence of a public health emergency, a lot of rules have been relaxed, and a lot of restrictions on telehealth, for example, other care delivery options. I think it's fair to say that a lot of middle-aged groups, a lot of middle-aged folks, when they consider the next year or two whether to put mom and dad in the nursing home, may reach a different conclusion than they would have even a year or so ago. And so how will policy dictate that, follow that trend, perhaps increasing reimbursement or incentives for home health? That comes with a different set of perhaps worries about fraud and other things that industry has sometimes had to deal with. So a lot of moving parts that they'll have to deal with. But again, I think the initial next 3-4 months will probably look like it would have anyway, had we had a continuation of the Trump administration. But the challenges of getting a vaccine scarce, at least initially, to the 50 states, how those 50 states then get it to their populations, given the refrigerating requirements that are necessary for this, is something that, again, it's going to be trial and error on the fly. Probably still expect some frustrations along the way, but we're hopeful that certainly if we're having this discussion 6 months from now, it'll look a lot better.
Great. And I see our survey results also show that I think a lot of our audience thinks things will look different in 6 months or so, with most of the survey respondents expecting that we would have 40% of the people in the U.S. vaccinated in either the second or third quarter of next year. So I'm hopeful that we'll get there and things will start to look more normal and be able to have gatherings in the summer that we can't have this winter. It's much easier to have a 4th of July barbecue than a Christmas barbecue, or at least on the East Coast. Sam and Mark, what does the change in transition look like for the industries that you're following? And Sam, now that we can see you, want to go first?
Yeah, let me do that again, and I hope my video doesn't freeze again. This is what happens when you try and do this from rural France. So, just about every single company has been asked the same question. What's going to happen with IPI? What's going to happen with MFN? And absolutely none of them give a committed response, or because frankly, I don't think that companies know. What they do know is that IPI, most favored nation, it's not just a decision that can be made by the administration and go unchallenged from a legal perspective. So I think the expectation from all the companies, although they don't actually say it, is that there will be some meaningful legal challenges, and I'm pretty sure, Beth, you could talk to that a lot. So that's the fact that we keep seeing. And I think investors have decided that generally, when you look at biotech valuations, there's no way that you can have a company, and I'm not saying whether it's high or low, but like IGM Biosciences had an interesting ASH. Share price is up fantastically, and I know Dan Chen quite relatively well, and I have high regard for him. He's the CMO at the company. But you're dealing with a company that's now at about $3.5 billion market cap. There's no way that valuation can be supported if the drugs are going to be a fifth of the price when they come out. So basically, when you look at the expectation these days is that an average oncology drug is going to come out at $130,000 or so $1,000 a year. Whether that's right or wrong is kind of a little bit irrelevant to the conversation. That is what the price is that they're getting, and maybe in Europe they get a little bit less, not always. So the point here is that we've got an investor base who is basically decided that that there's not going to be an impact from any of this on our pharma companies. So if anyone can come up with a good argument as to why it's really going to happen, I think they'll be toasted in two ways: either toasted with a glass of champagne, or toasted by investors because they don't like hearing it, right? Roasted, more like. So I think that's the issue that we have to think about. How real is the possible reality of any of this becoming a reality? And I think basically most people are currently assuming that it just won't happen. And I think Brian and I have marketed together to buy-side clients for several years. Everyone's got the same questions, and he keeps repeating the same thing. And of course, I'm not going to take his words, but I do remember him saying, don't forget that during the Obama administration, we had a Democratic Senate, Democratic Congress, and then a Democrat in president, and actually nothing happened. Now, again, I'm not judging whether that's a good thing or a bad thing. It's the fact. So whether this time is different, we'll see. But the reality is that we've got a situation where I think you've got to give something. And all the pharma companies are in favor of the rebate reform, because obviously it makes them look a bit better, because the prices, when they're net prices that people talk about as opposed to list prices, it looks a bit better. So Mark, on to you.
Yeah, I agree with all of that. I guess I'll add just a couple of things. On the MFN front, the commercial stage biotech companies haven't really, when they've had commentary, it's been sort of along the lines that you alluded to. Although one comment stands out, and that actually came from Alexion, which sort of touts the fact that they have a fairly narrow global pricing band for their products. Now, whether that was done with foresight in anticipating something like this, or managed to come to pass through other ways, I'm not really sure. And the fact that I'm bringing that up as an interesting comment means they're the exception, not the rule, I would say. But I thought that was sort of interesting. I guess just another general pricing comment as it relates to some of these newer cell and gene-based therapies or potential therapies. We're starting to see, in the case of Bluebird's thalassemia gene therapy, which is approved in Europe, where they're splitting the price up over 5 years equally in equal increments, and only the first year's payment is really obligatory, and years 2, 3, 4, and 5 are success-based. Now, whether that will factor into future trends or sort of have a mitigating effect towards some of these, price control policies, I think we'll have to wait and see. But that's another interesting development, I think.
Yeah, Mark, just as a matter of, sorry, Beth, I think similar structures, although they're not exactly public, are in place for Zolgensma from Novartis, because few people can fork out $2 million in one go, so or would like to. I'm talking insurance companies here, right?
Yeah.
Yeah.
Sorry, Beth.
No problem. I was going to provide a little more information about MFN because, as you noted, there are legal challenges, and I want to disclose that I'm counsel to one of the parties that's challenging the rule. So yes, we are definitely seeing legal challenges. 2 cases were filed last week. The one that one of my clients is involved in, the Association of Community Cancer Centers versus Azar, and another one, Bio versus Azar, filed in 2 different federal courts. Both hopefully moving to get a resolution before the MFN rule takes effect on January 1. And for those in our audience not entirely familiar with it, I'm sure though a lot of you are, this is a rule that the Trump administration issued a few weeks ago as an interim final rule, meaning it takes effect immediately. There is a comment period, but it'll be in effect before the comment period ends. And it would, as of January 1, change the reimbursement rates for 50 drugs under Medicare Part B to take into account a mix of international pricing and the U.S. reported average sales prices that are conventionally the basis for Medicare Part B reimbursement. It's a 7-year model where the rates will be phased in over the first 4 years, and it's expected to reduce Medicare spending on these drugs by $85 billion over that 7 years. Is a much larger reduction than the international pricing index model that the Trump administration had issued an advance notice of proposed rulemaking, but not an actual proposed rule, more of a, here's what we're thinking of doing, but still lacking a lot of details, document 2 years ago. That would have had a savings of about $17 billion over 5 years. So this is, it's been described as a parting gift, with scare quotes around it. From the administration. It's obviously raised tons of questions for industry about what will happen when and if it goes into effect on January 1. What would the long-term impact be as it's being phased in? What could an incoming Biden administration do with this thing that is a final rule if the court has not blocked it before the new administration takes over on January 20th? And of course, lots of questions about the longer term implications for pricing, the creative models that Mark and Sam were talking about, as well as some just factual problems with the rule and concerns about how it would be implemented, a lack of transparency about the international pricing used, choices of some drugs that aren't actually marketed in other countries, things like that. So it is obviously one of the hottest issues we're looking at, both how it would be implemented, the legal challenges, and what potential long-term effects might be if this rule isn't implemented, or if it gets blocked, what will come next in drug pricing. And as Mark and Sam were saying, there's an expectation something will happen, but we've seen in the past, and I'm sure Brian can speak to this more, that even when you had complete Democratic control of Congress, or even in this administration, where you had the president pushing for pricing reforms and bills being passed in the House and reported out of committee in the Senate, still no action happened. So what will actually happen, we'll see. Brian, do you have any thoughts you want to share on this before we turn back to some COVID issues?
Sure. And again, if I knew the answer, I would probably be somewhere else right now. But these are key issues. And I think you touched on something with the MFN in particular that makes it a difficult political animal to implement. And that is, pharma is an easy political target. But it's not pharma that gets directly hit by the proposed MFN regulations. They're not technically lowering the prices for these Part B covered medicines. They're proposing to lower the payments to providers, to the oncologists, to the ophthalmologists, to the specialists, and that's a much more politically sympathetic group. And so thinking back to the Obama administration's efforts 5 or 6 years ago to slash ASP plus 6% down to a combination of a 2.5% markup plus a flat fee, that was opposed by every Democratic member of the then Senate Finance Committee. So there's a lot of pushback there, and I suspect the incoming Biden administration is rooting very hard for the legal challenges so they don't have to deal with this. Because you're right, an international pricing index model is at the heart of a lot of progressive Democrats' wish list in Congress, but when push comes to shove, it's proven to be very difficult to implement, and I suspect Biden would not want to deal with this anytime soon. On the rebate rule, it's sort of an opposite. And as Sam mentioned, the pharma is pretty much in favor of this. It's the PBMs, the insurers who are opposed to that. Biden may be a bit more aggressive here, and he has a couple of options, I think. First, there is a 60-day period between when this final rule was published in the Federal Register and when it can be implemented. Well, it was published on November the 30th, which means it can be officially implemented on January 29th. You can look at your calendar and see that that's 9 days after President Biden takes office. And so if he or his incoming chief of staff want to simply freeze regulations, I think they have the option to do that. If they don't want to do that, there is also the fact that those proposed provisions the largest provisions go into effect in January of 2022. So certainly the insurers would want to have, know the roadmap when they start setting rates in the spring of next year. But there is some time if they wanted to make a change and either adjust or change that. But that is a rule that while Pharma likes it, Democrats don't. And so Nancy Pelosi's been very outspoken in her opposition. They consider that a giveaway to the pharmaceutical industry. So I don't know that the Biden administration will be great fans of the proposed rebate rule as it's written down, at least. Maybe they make some adjustments. Last thought I'll bring here is you did mention if they can't do that, what can they do? And so you do look to areas where there has been bipartisan agreement. And I think conceptually where there is an agreement is under a restructuring of the Medicare Part D benefit. Both Democrats and Republicans want to give seniors an annual out-of-pocket cap. That's a very politically popular thing to do. Both Democrats and Republicans want to reduce the taxpayers' burden in the catastrophic phase from 80% now down to 20%. Both Democrats and Republicans want to eliminate the so-called donut hole, the coverage gap, entirely, and shift pharma's burden out to the catastrophic phase. If that happened, winners and losers. Winners would probably be the insulin manufacturers, others that are really hammered hard right now by the donut hole. And the losers would be those, think, higher priced oral anti-cancer drugs that don't have any additional financial burden now under the Part D structure, but which would take a hit there. So if, everyone tries and fails, if Republicans keep control of the Senate, Democrats can't pass anything they want to do, but they decide in the next year or two that they want a drug pricing win, I think they might focus on those out-of-pocket costs and that out-of-pocket benefit in the Part D program.
Yeah, and I think that points to an important distinction that I think is often missed in some of the discussions about drug pricing. Are we talking about what the drugs cost to the healthcare system, or what they cost to the patient? And some of that Part D restructuring would involve focusing on the patient and how much the patient's out of pocket will be. It'll have effects for the plans too and the benefit overall. But a lot of when I get asked questions about drug pricing, I always said, well, whose price are we talking about? Is it the price to the Medicare program, the price to the physician, hospital, or pharmacy that buys it to the health plan, or ultimately to the patient? And the political pressure should be behind lowering the price to the patient. But, all these things get intertwined and not always sorted out very efficiently. And I want to point out our second survey question had asked about how do you believe U.S. and European drug pricing will be impacted by the massive macroeconomic drag of the pandemic over the next 2 to 3 years. Pretty evenly split between saying it would be relatively unchanged or decrease less than 10%. And that may point to some of the resilience that I think some of our speakers are seeing in the industry. And I want to pivot to that back to from COVID, and I think what Sam had referred to as a transition year, as the industries come out of having dealt with the pandemic strains in 2020. There are challenges to actually delivering products to patients and running clinical trials, as well as the just overall economic impact on consumers and healthcare systems paying for the drugs. Going into 2021, as we have vaccines become available, as we may have more COVID therapies, how are you seeing the industry responding or continuing to respond to the COVID part of the healthcare picture? Mark or Sam, who would like to go first?
Sam, take it away.
Okay, well, so if I understood the question correctly, Beth, are you talking about vaccines specifically, or just generally COVID and the shape of the pandemic?
Let's start with vaccines, because that's obviously the thing getting most attention this week in a lot of countries.
Yeah, I mean, I think I go to bed dreaming about vaccines and I wake up thinking about vaccines all the time. So we're in a very lucky position to have 3 vaccines. Let me do it this way. I have lots of criticism of the AstraZeneca vaccine. I was probably the only one at Bloomberg in the organization that was negative about it when the first data hit, whenever that was, a week and a half ago, 2 weeks ago. But we do have 3 vaccines that all have shown a significant reduction, seriously significant, highly statistically significant, in the small numbers still, of hospitalizations and severe COVID. So that is the positive to take away from this. Whether the efficacy of one is 90% plus and the other one is 70% plus is debatable, at least the 70% one. I don't think we can debate the 90% one. We've seen the FDA documents, whatever subgroup you look at, you're dealing with 90% plus. So the interesting thing, of course, is that, okay, so if we have 2 vaccines that are at that level of efficacy and people see that, and they're probably more incentivized to go and get that vaccine. And you have another one that's caused a lot of questions and discussion. And I can tell you, I had just today, a conversation with one of the governments who bought the doses, who ordered the doses, asking what would be my assessment of the data so far, which I was obviously very pleased to have been asked. But all I'm trying to say here is that they're all wondering what to do next, right? And the points that they bring up is that it costs very little in terms of buying it, the Astra vaccine, and we can get lots of doses because there's a lot of it's been done through technology transfer. So, of course, the element here that nobody puts in the equation is that they're calculating this side of it. If there is a question mark in people's minds about the efficacy of the vaccine, unless they're forced to take it, and I think we can fairly say there is a question mark. If they're forced to take it, then fine. If they're not, then I don't think people will go and voluntarily line up to get the vaccine, unless they know it's one that's going to give them a high level of protection. So that is where the risk is, that if these governments go ahead and buy and continue. On the other hand, they might just decide, look, we're going to force our population to do it. Everybody needs a vaccine certificate. You're not going to be able to travel unless you have one. You can't go into a restaurant. You can't go to a theater. I mean, these are rich world problems, right? You can't get on a plane. You can't get on a train, say, unless you have that little piece of paper or whatever it is, unless you've had it. That's different. But if they're going to leave it open, I think there is a question mark here that has to be dealt with, and I'm hoping that their data will show it. So what happens with the AstraZeneca vaccine, what happens with the next vaccines that read out, Novavax and Johnson & Johnson, are important in trying to figure out the shape of our recovery, because nobody is going to have enough doses of the Pfizer-Moderna vaccines, Pfizer-BioNTech and Moderna vaccines, to be able to get to herd immunity that quickly. We do need the other vaccines. So that would be the only, we can go into as deep a conversation as you like on each vaccine, but that would be my overall view of it.
Thanks, Sam. And I think that the questions about the distribution and the trust inherent in that will be a little bit different in every country, but I see from the American perspective, that's something I'll be watching personally very closely over the next few months, as I'm hoping that the highest risk members of my family will be able to get the vaccine probably well before I can. Mark, what do you see in this transition here as industry responds to and comes out of hopefully the pandemic?
Sure. Yeah. And before I do that specifically, I'll just relay something that Dr. Fauci said. Someone said he's going to continue to be everywhere. We're just coming out of the American Society of Hematology conference, which is one of the big cancer and benign hematology medical events of the year. And of course, he was virtually there sharing some of his views. One of the things that he said that really resonated with me was that to really prevail against this pandemic, we are going to need extensive global deployment of the vaccine, not just in the resource privileged parts of the globe, shall we say. So I think that remains, we've been talking a little bit about some of the potential distribution and acceptance challenges in the United States or in the UK or France. I think, those issues will need to be addressed on a global scale. And we will probably need, not just 2 or 3 successful vaccines, but hopefully additional vaccines to make that happen. I guess I'll also say, just from an industry viewpoint perspective, some of my, and I'm sure Sam's kind of cautiously optimistic view of 2021 is predicated on continuing momentum in terms of vaccine rollouts. We're obviously in the midst of pretty significant virus resurgences. I mean, I think Sam is in a lockdown in France. My in-laws are effectively in a lockdown in Los Angeles, and that's playing out, many places. So that's sort of the wild card, as we go into 2021. I guess I'll also say that, obviously the focus needs to be on vaccines, but we've had a handful of therapeutic approaches that in one form or another have received regulatory clearance. We have a direct antiviral from Gilead, and then we have some anti-spike protein antibodies, either cocktails or single antibodies from Lilly and Regeneron. I think those all have the potential to play a role, hopefully over the short term. I've never been of the view necessarily, although there could be some stockpiling orders, et cetera, that they will be long-term, shall we say, revenue drivers for those companies. And they do all kind of have some wrinkles in their data and need to be given intravenously, which in the case of the antibodies, again, poses some delivery problems that I think we've alluded to. So I think those are a useful component to our response, but it's really more about getting additional vaccines to come online and deploying them broadly.
Oh, yeah. Great. Thanks for your thoughts on that. I think we're nearing the end of this part of our discussion. And before we turn to questions, I just want to tie a couple of threads together there. With everything I'm seeing too and experiencing in my own life, a lot of hope is resting on getting these vaccines out. And because we do live in a global economy and this is a global industry, we need those vaccines available to people in all the countries that are part of producing and delivering innovative healthcare technologies to patients. But we're also looking at some of what we talked about earlier, the changes in how healthcare gets delivered and greater use of telehealth and digital medicine, things like that will hopefully continue to be solutions for the rest of the pandemic that may also become more permanent solutions. As we're heading into this winter of increasing strains on hospitals, hopefully we'll see more use of those technologies and more patients getting comfortable with them so they aren't falling behind on the healthcare that they need that's not COVID related in the meantime. So, Sarah, do we want to turn to some questions now?
Hi, sorry, in the middle of all of that, I had a delivery coming to the door, and I don't know whether anybody heard, but dogs started barking, and things are not always as sane as they. I'll tell you, in this Zoom world, it's really, really crazy. So for anybody who has to leave, I do want to just initially thank all of you for this really enlightening discussion. And we've had a number of questions come in over the transom while you've been speaking, including a few hellos from Punjab, India. So we do have viewers from all over the world. And I think one of the questions that focused on the most favored nation status is a question that has been addressed pretty well by you. So one of our questions is, given most likely a divided Congress and a more conservative Supreme Court, please handicap the odds of a public option being reintroduced into the ACA in new legislation.
This was part of the candidate Biden's platform, is to transition the Affordable Care Act from Obamacare to Biden Care, and that would include a public option. Brian, what do you think? You're laying odds on this.
I think it's unlikely. I think if we had had a so-called blue wave where Democrats had expanded their House majority, had gotten a clear Senate majority, then something like that potentially could have gone through a budget reconciliation route, the same budget, in the same process that Senate Republicans used to pass their tax reform bill in 2017. But given that I think it's going to be very difficult, irrespective of who controls the Senate, for the House Democrats to get many of these progressive items even from the House to the Senate. We're looking at maybe a majority of 222 to 213, something like that. If Biden picks off a couple of those members of the House, 220, so she can lose at most 2 or 3 votes if everyone else sort of sticks to their party lines. So I don't know that they're going to do that. And I certainly don't think that if we do have a Democratic-controlled 50+1 majority in the Senate, that Pelosi and Schumer will want to embarrass each other with bills. That I think Pelosi is happy to try and pass things in the House that can't become law if it makes Mitch McConnell look bad. I think she's less willing to do that if it puts Chuck Schumer in a tight spot. But yeah, I think the public option is unlikely to be included anytime soon, and we can perhaps revisit that in 2 years following the 2022 midterms with that. But administratively, again, I think it's going to be more focused on rolling back some of the Trump administration's unilateral actions, more so than trying to insert the public option.
Yeah, I agree. That's been my understanding too. And I think as we're looking at some of those administrative actions, I think it'll include greater advertising, greater support for people enrolling in exchange plans, maybe opening up more enrollment periods based on people having lost jobs, as well as changing some of the administrative rules that apply to the Medicaid programs, where the Trump administration had encouraged states to link Medicaid expansions to work requirements. I mean, the Biden administration will try to encourage expansion of Medicaid for the sake of covering more people, and especially with the financial constraints states are under, if they can make changes while they can get a better federal match, or try to approach expanding coverage through legislation to help with the federal match, that might be a less difficult lift than creating a whole new public option.
Okay, thank you for that. Another question has come in, and this is a more global question. The viewer asks or states that many biotech and pharma companies have pivoted from their traditional core development pipelines to focus on COVID-19, even in fact when they are not focused on infectious disease prior to the pandemic. How quickly will their return to their core disease areas, whether it's oncology, neurodegeneration, or whatever, happen? And will they continue to get commensurate VC funding? So I think this is a Mark question and perhaps even a Sam question.
Yeah, I mean, I appreciate that question. I guess I will say I hope that if the pandemic has served any kind of useful purpose, it has clearly demonstrated that we need to be focusing resources on every level, from public health to science and drug development and innovation, on infectious disease broadly. And I hope that continues. I mean, I think implicit in this question is that it has not traditionally been in vogue as an area of focus, certainly for larger biotech or large pharma companies for various reasons over the years. So there is sort of that precedent that will have to be bucked, if you will. I think amongst the biotech companies, you certainly have, have companies like Gilead that have been involved in antiviral therapy that move quickly. Here you have Regeneron, which has one of these antibody cocktails recently approved for Ebola, and obviously are quite active on the COVID-19 front as well. I guess I don't have any metrics on this, but I guess I would hope that level of innovation and pivoting also maintaining that smaller emerging biotech companies that they get funding and that, further upstream, larger biotech and pharma companies remain receptive to those efforts. I don't know if Sam has anything to offer there.
Yeah, I mean, so the vaccine space was probably the least sexy biotech space that ever existed until this issue came up. So I think if we go into a world where we are going to be more pandemic ready, and that there is an acceptance of that there is a future in it. The problem is that you're kind of hanging around for business to occur. And it's a bad day if business arrives because another pandemic has started. So that, I think, ends up being probably the companies that have already moved forward with their technologies, either the Novavaxes of this world or Arcturus or Moderna or BioNTech, etc. So I don't think that there is going to be much new needed there. If there are new technologies, I wouldn't necessarily finance a company, if I were financing a company, to think about the next coronavirus therapy, waiting for a coronavirus outbreak. I mean, that's the sort of thing that governments and academia should do. And let's face it, the reason we've been able to get a vaccine so quickly is because academia had done all the work on MERS and SARS.
Right.
And that just fed straight into this vaccine. So I think that's one element. And then, of course, on infectious diseases, yes, I get the idea that now people perhaps are a bit more understanding of that. But, I mean, that's not, we've had Hep C, massive investment in hepatitis C, hepatitis B is probably one that's interesting to look at. RSV is now becoming more and more interesting. So that's something that I think is going to continue to be an attractive space to invest in, so long as you can make money out of it. The problem with antimicrobials, in terms of antibiotics, is that they're still not sexy. So I don't think that. I don't think anyone's going to go and say, right, I need to invest in an antibiotic company in case we get a massive outbreak of resistant bacteria.
Yeah, I'm talking to a company. We're focusing in on doing a session on antimicrobials, and one of the theses behind it is patients who receive very expensive chemotherapy therapies for oncology wind up dying from secondary or tertiary microbes. And after spending all that money saving somebody's life, there's very little investment on the downstream possibilities of other microbes that infect and kill people. So,
well, let me know when you do that. I've got a company that I can introduce you to.
In 3 months, and we will talk, because there's a small group that wants to make a bigger deal about this. And I love the fact that it's evening now in France. Your window, it's gone from blue to dark.
Glass of whiskey.
Yes. Okay, a quick question. We have a question that came in. According to NPR, the UAE has reported that the Chinese vaccine is 86% effective. You may be closer to that, Sam. Have you heard that?
Yes, we've even written a little bit on it. The problem is, I spend my life making tables of side effect profiles and efficacy profiles and everything. I've got nothing to go by. I'm not saying they're not telling the truth, but I don't know what that means. Sometimes these announcements confuse seroconversion, for example, with immune response, and you don't know what's it based on. So I take them at their word. I'm sure it's possible. We've seen phase 1, phase 2 data for that vaccine published, and it's immunogenic, which is not a surprise given that you're injecting pieces of the virus into people. And it uses a basic alum as an adjuvant. So maybe people should start looking at a French company called Valneva a bit more, because they're partnered with Dynavax with a more clever adjuvant. And we all know that adjuvant makes the difference here in these things. So,
okay, thank you for that. Another question about FDA, and this is for Brian and for Beth, actually. Is there any hope that the FDA will be mandated to actually use 21st Century Cures Act to rapidly approve EUAs for repurposed anti-inflammatories?
Beth, if you want to take that one first, go ahead.
If you don't,
yeah, I'm not sure what to say about there. I think there's 21st Century Cures Act, it's now 4 years old, and obviously laid out some changes in how the FDA works. We're getting a lot of experience with EUAs in the last year. But I think the word mandate is what jumps out there, is that we're also looking at a period where having trust in what the FDA does is paramount to successful rollout of the therapies that do get the EUAs. So, and my practice is not focused on FDA law, but I would just caution anything that looks at the word mandate as suggesting that some part of the government, the White House or Congress, is going to tell FDA, you must approve something now, or you must approve it faster. They may change the process, but I think, especially with the change in administration, will be an even greater focus on maintaining the scientific independence and integrity of the FDA.
Okay, great.
And the other thing I would add to that is, probably in a few months, this summer, you'll start looking at the next 5-year, FDA user fee reauthorization process.
Right.
And it's possible they could look at a 2.0 version of 21st Century Cures and even change that law itself sometime in 2022.
Okay, great. Thank you, Brian. Thank you, Beth. A question comes in from Europe. May I ask what level of herd immunity rates actually are needed in order to control COVID-19? I think this is for our PhD and our doctor, perhaps. Mark and Sam?
Doctor, shall I take that?
That's a PhD level question, if I've ever heard one.
Okay.
So I keep telling everybody that that particular question is a simple equation. That is the number of people vaccinated multiplied plus or whatever number is current immunity. So, I just had an email from a client who's very actively interested in this, said, he thinks that 70 million people in the US probably already have had COVID and have got an immunity level. So you take that number, then you take out anyone below the age of 18, because they're not going to get vaccinated anyway, because the trials haven't been tested in them. So that leaves you only, like in the US, for example, I know this question came from Europe, but the US's numbers are in my head, 250 million people, take out 60, 70 million out of that, you only need to vaccinate about 70% of the remaining people to get to
herd immunity.
So-called. But you also have to be aware of the fact that we still don't know what the durability of this vaccine is. And I'm very hopeful. I'm very, very hopeful that it will be more than a year. But that, of course, comes into the equation too, because if it's short, then by the time you get to the end person, you have to go back to the first person.
Okay. Mark, do you want to add anything to that? Or should we move on?
No, I think we'll move on.
Okay. Another question. Will we see progress in the pay-for-performance model for pharmaceuticals under the Biden administration? I don't know. Brian, maybe. Brian and Beth, maybe?
Yeah, I don't know that you're going to see massive progress. I just don't think, at least initially, given everything that's going on, both with the pandemic and their own priorities, it's just not an area that I think is going to be an initial area of focus. Not to say that something can't get done or won't get done administratively, but again, I don't suspect that that's an area that they'll want to do. Again, maybe if there's a bipartisan effort in Congress to fall back to some sort of drug pricing program that focuses more on out-of-pocket costs for patients, they could focus on that. But I suspect there will be other health priorities that we'll see in the first 100 days for Biden.
Okay. Beth, do you want to add anything, or shall I move on?
Yeah, I would say that's my impression that pay for performance and value-based payment are kind of entwined concepts. It's a lower priority, and pay for performance in other settings, like pay for performance for physicians and in some of CMS's models, have all had to be delayed or sort of extended because the pandemic has reduced the number of patients whose performance and treatment can be measured. So those things also take a long time to roll out and be fully implemented.
Okay, thank you. Another question, we're getting close on time. So the next one is, under the Biden administration, how will the regulatory landscape and the funding landscape for digital medicine change? And do you think pharma companies and payers will be more interested in partnering with or acquiring digital therapeutics and diagnostics? Now that's a 2-minute answer, right?
I'll just do a very quick one on that. Digital therapeutics, you know, the pharma companies have not quite gone to digital therapeutics. I don't know what that is actually, but we know that Roche, for instance, and we know that Novartis and several other companies are really interested in the application of digital, you know, technology to being able to conduct their business. And for example, testing. So Flatiron, Novartis has been talking about digital transformation for as long as Vaz has been there. So that there is interest there. I'm not sure if it's going to be through M&A necessarily or partnerships.
Okay.
On the regulatory side, at least from the reimbursement side, because that's the part that I work on, one of the hurdles to investment and further development is where reimbursement stands now. Can you actually get paid for using these technologies? And I think policy will continue to evolve, particularly growing out of our experience this year, with recognizing the benefits to delivering healthcare to patients where they don't necessarily have to go to an office. So I've been hearing a lot about like app-based technologies, ways that patients could assess their own conditions without having to go back to the doctor's office to do something that don't necessarily fit into Medicare's reimbursement models now. Commercial payers may have more flexibility. And I think we'll continue to see policy on that evolve as the American Medical Association is pushing for coding, and that means like the Medicare on payment, and then the models, the codes and payment structures exist for other payers to use.
Okay, yeah, and I think there are 1 or 2 companies that have already gotten approval for reimbursement for their digital technology, their digital therapeutics. And I know it took a very long time for that to happen, 8 years in one case. From another question, it appears because of COVID that there's been an upsurge in home delivery of prescriptions via organizations such as Express Scripts. Assuming that many consumers don't resume at pharmacy pickup of their prescriptions, what will the impact on the contentious PBMs or pharmacy benefit manager industry be? Any guesses on that one? Will it impact them?
Can I just say I haven't thought about it? That's a really interesting question, and I have not thought about it. I don't know if anyone else has.
Brian?
Contemplated.
No, you know, our colleague Jonathan Palmer follows the space and does a great job. We can point people to his research after this call concludes. I suspect, given the increased vertical integration between PBMs and insurers, you know, that line has been muddied, you know, a bit more. I do wonder, I was reading earlier, the questions about, you know, what will CVS do? CVS, obviously, one example of a pharmacy, and they're all trying to address that trend themselves. And it's probably another one of those cases where the industry will lead policy rather than the other way around.
I think it's also worth remembering, and I know Jonathan has written about this, you know, about Amazon's move into this space. It's still early days, but, you know, they are certainly thrive on disruption, and, you know, given those elements of the pharmaceutical distribution system are sort of already disrupted by the pandemic, as the questioner was alluding to, I think, you know, that only kind of ratchets up the potential for this new entrant to kind of reshape things.
Okay. I've got one question, and this is a global question, one that we haven't really addressed yet. You know, if the pandemic happens in some other part of the world, eventually it will get to the US or Europe or wherever. So this question is, what about the status of Chinese vaccines, and what about the vaccine supply for the developing world? If an outbreak occurs there, it will get here. So
yes, sure. But of course, so I don't know exactly what the question is, because we already have outbreaks over there that have reached over here.
Oh, no,
So
it says it. But what about the supply? They want to know, how is the vaccine supply going to get to the developing world?
Oh,
I mean, I think
Yeah, so a lot of the other vaccines, so Sinovac vaccine is a killed virus. Valneva is a killed virus. And AstraZeneca is the viral vector. They all only require normal refrigeration. So so that's one element to think about. And AstraZeneca has been quite clever in the way that it's done it. They've just done technology transfer. So for Brazil, there's a local company that's manufacturing. For India, it's the Serum Institute that's manufacturing. So those are the elements that take care of that. And then, of course, you've got this other issue that we should not forget, that we all think the developing world is incapable of managing a cold chain. And I do understand, I've been shouted at several times for this, the Ebola vaccine requires a -60 freezer. And I'm not saying that Ebola is anything like COVID-19, but of course, it was doable, and they did it.
Wow.
And of course, then we have COVAX too, which has got lots of doses being donated to them from the various countries.
So you're confident that the developing world is being taken care of with regard to vaccine supply, as well as it can be?
Well, I mean, to be honest with you, Sarah, the confident, I'm never confident when it comes to greed and wanting to be first in line. At the end of the day, I do think that some countries are likely to suffer because of their inability or not having been in line, but the rest of that comes down to the philanthropic organizations, to be honest.
Right.
So, and again, don't forget Johnson & Johnson's at cost, and they can do billions of doses too. So it might just take a bit longer.
So I have another question that this is specifically referring to mask wearing in the U.S. If masks were mandated by federal or state law, would that actually work in practice? Who would police this? Would people get ticketed?
So one of the things that President-elect Biden announced this week, maybe yesterday, because every week feels really long since March, was that he would issue an executive order calling for masks to be worn on buses and trains, basically require them on interstate transit. And so I think what we'll see, we have not yet seen states, with the exception of Hawaii, which was discussed in a news article this morning, that we're turning to law enforcement to enforce their quarantine mandates or mask wearing mandates. And I noticed as I was driving into the office, I passed a DC cop who was talking to somebody who pulled over on the side of the road, and neither of them were wearing masks. So I'm not really counting on the police to enforce the mask wearing if their own mask was being worn as a neck gaiter. But I think what we're more likely to see is an executive order or mandates that say you can't participate in certain kinds of activities. So really what I think Sam was mentioning before about vaccines, what if we make it a ticket to entrance? As we've seen in the last 8 months, most, I think, mask enforcement has unfortunately fallen to businesses who have to stop the person at the counter or at the door. I can't serve you unless you put your mask on. I don't think we're yet as a country at a place where we're asking the police to enforce that. But I think we are doing the transition into the Biden administration trying to reinforce the culture of people wearing masks, and his President-elect Biden's likely emphasis on asking people to wear masks for 100 days will be part of that.
Civic duty, basically civic duty. Right. So our final question is, will the incoming Biden administration be an administration that has a positive effect on innovative early stage companies? And if so, how? We have a very vested interest in that.
Well, I guess I'll start. I'm sure everyone has thoughts on that. Recall that President Biden himself, after his days as vice president, was involved in the cancer moonshot program. It's something that is very close to his own personal family, his own personal experience. So I think his administration will continue to want to invest. I think that's likely to find its way through the system in terms of increased funding for the NIH, trying to fund, again, boost funding even more for the National Cancer Institute, other of the so-called 27 centers and institutes within the NIH. So I think there'll be more money plowed into there. But I do think an earlier comment about downstream, wanting to restore the FDA's credibility based on some of the comments made by President Trump and others, may result in FDA leadership that is more academic than industry focused and perhaps slow down near-term approvals. But I think at the earlier end, I would expect Biden to want to increase innovation. And again, go back to the next 5-year FDA user fee reauthorization process that's going to play out over the next 18 months. That will involve lots of innovative provisions in that legislation as well.
Oh, thank you. Thank you very much, Brian. And I think that's our last question. Beth, I want to thank you for moderating this discussion today. I think we could go on for probably another hour discussing policy and everything going on, both in Europe, here in the US, and around the world with regard to drug development. I want to thank Bloomberg for sponsoring today's event. And please remember for all the viewers that there is a document that is posted on our website for you to download. I thank the audience for joining us. I thank all of our sponsors that are ongoing for supporting us in this. And I'd like to invite everybody to please join us for the next Demy-Colton virtual salon, The New Alchemy of Investing in Health, which will be really interesting as well. It will take place on December 16th. Until then, stay healthy and safe, everybody. Thank you.
Thank you.